Good morning, everyone. If I could ask you to take your seats, we're already running a little bit behind, so we'll try and catch up a little bit of time if we can. We're going to start the second session. There's going to be some instructions following Professor Dilwani's talk about where to go. So before we do that, if you can all just have a little look at your badge and make a note of the colour on it, we'll come back to that later. But in the meantime, I'm going to waste no time in introducing Professor Dilwani, who I would argue needs no introduction whatsoever. He's going to talk to us about the new BSG guidelines in polyps and IBD.
Thank you, Rodri, and thank you to WAGE and BSG for asking me to present on two recent guidelines that I've been involved with the BSG. These are very practical guidelines, and I do hope that they help us to change our practice and improve our patient outcomes. So without further ado, I have no conflicts of interest. And the first guideline I'm going to start with is the colorectal surveillance in IBD patients. I'm not going to cover the full IBD guidelines, and we're really going to talk about when, how, why, and how practically this guideline is going to be of help to us. So the first question really is why? Why do we want to do this? And why offer colonoscopic surveillance for patients with inflammatory bowel disease? Well, the simple answer, as we know, is to prevent IBD-related colorectal cancer. But do we really prevent IBD-related colorectal cancer? Let's have a look at to what extent and how we do that. And this is mainly because there's an overwhelming amount of evidence that patients with IBD are at a higher risk than the general population from developing and dying from colorectal cancer. So if we look at the cancer death risk in inflammatory bowel disease on a population basis, and this is broken down into men and women, and just for simplicity's sake, also broken down not just over periods of time, but also in the biologics era, what we can see is that the mortality from colorectal cancer has been trickling down, as it has been overall as well. But what we can also see is that this is a key part of our evidence when we look at what have the biologics done and in what ways have they improved the lives of our IBD patients. And on the right, you see, if you take nothing home, take those few messages home, because these are the things that have helped to reduce that mortality and continue to do so. Ask your patients to stop smoking. We need to achieve better disease control, and I'll talk a bit about why. And more effective surveillance. We'll talk a bit about how the guidelines help us to know what is more effective and how surveillance is more effective, and timely colectomy for those who really need it. At the same time, we also need to be aware that we don't do IBD surveillance colonoscopy well. There's now, I hope all of you are aware of recent data as well on post-colonoscopy colorectal cancers. And what is clear from these data is that the post-colonoscopy colorectal cancers in IBD patients are disproportionately higher. We don't do these colonoscopies well for a variety of reasons. So does colonoscopic surveillance in IBD actually prevent colorectal cancer? Let's look at this a little carefully. And in the interest of time, I won't dwell on it too much, but it looks like if we look at all the trials there, it does seem to. How does it do that? So these are really important concepts to understand. So what you see on the top is you found the cancer, you detected the cancer by doing surveillance, which you may not have done had you not done surveillance otherwise. You reduce the death from colorectal cancer, so you reduce the mortality. But what the lower two rows show you is that you actually changed the stage at which that cancer was diagnosed. And that is a key difference when you're looking at survival and mortality. That is very stage dependent in these patients. So you're not just preventing the cancers through our interventions, we're also detecting them early, and we are causing, or hopefully causing, a stage migration to improve overall survival. When should we do this? These are all things that you'll find in the guideline recommendations. This is just about understanding what these guideline recommendations are about. So if you look at when the cancer risk starts rising over here on population data, 8 to 10 years. And if you look at the really well-characterized Danish IBD cohorts versus the population colorectal risk, you'll again see that this is where at the BSG guideline committee, we took our risk stratification when it starts going above the population colorectal cancer risk, which is when surveillance makes sense. Whereas it's really different when you look at some high risk groups, PSC, your risk of cancer starts going up almost from the time you're diagnosed. So very different cohort. So the other thing we've tried to do throughout these guidelines is actually tease out clear risk stratified groups. Not every patient is a one size fits all, needs surveillance, doesn't need surveillance, but actually each group has got to be looked at separately. And what you'll see here is that does everyone need colonoscopic surveillance? If you look at those risk stratified groups, I'll go into those in a moment, clearly not all, and clearly not to the same intensity and to the same frequency. And this is really data driven. It is not really about saying, oh, you've got colitis and it's been 10 years, so off you go, you're going to have a colonoscopy. Not necessarily. Let's have a look at that. So this is the key flow chart over here. And what we'll see over here is that you have to have a baseline at the time, at the point when that IBD colorectal cancer risk starts rising above the population level. And then a key aspect of methodology in these guidelines was that you might find, and this is a funny thing, one of my fellows has recently published on this, is you have the same evidence that is looked on by different professional societies across the world, and then you have slight differences in recommendations. Why is that? Now, that might be because of the way healthcare systems are set up, the way reimbursement works, whether it's insured versus non-insured patients, and all sorts of things. But this is hard evidence-based guidelines. You cannot argue with these because these are all the data in the world all together. So what are these risk stratified groups? They're self-evident there. What we've done again is instead of the classical univariable method of trying to look at just risk factors and saying, oh, you've got a few risk factors, we think you're going to need surveillance, looked at which risk factors, looked at the age adjusted risk for that, looked at the duration, looked at all of those, and applied some very rigorous modeling techniques to look at who's truly at risk and by how much. So when you're actually explaining to a patient by how much is your cancer risk more than the baseline population colorectal cancer risk, that's what the difference is. The other key difference is with a lot of the old guidelines, they were also in the non-screening era. You've now got a bowel cancer screening program, which is starting from age 50. And it is really key that people participate in that as well. And so your IBD risk at a certain level may be sufficient for you to have an additional surveillance, or you may be sufficient to just go into the bowel cancer screening program. And this multivariable risk model, I won't talk about it too much more, but there's a risk calculator here. You'll see it in the guidelines as well when you read it. And this is really easy. You see a patient in clinic, just put the link of that risk calculator on, put your patient's details on. It will take you less than a minute, and it will give you the risk category, the risk stratification. Again, this was done with our colleagues in Holland, who built a really robust risk prediction model. Again, the details of that are given all in the guidelines and the supplements, but we looked at this really rigorously as to each set of scenarios and what the level of risk was that it entailed. So hopefully it's a very practical way of actually assessing someone's risk and then assigning a surveillance frequency and interval to that risk. One thing we don't do well is know when to stop. We keep doing surveillance in people and they may have 10 other things wrong with them and we're still carrying on doing their colonoscopic surveillance, which is clearly and completely inappropriate. It's a theme we've heard through this morning about reducing inappropriate procedures. I'll talk a little bit about this table again when we come to the limited life expectancy in polyp management, but this is essentially about knowing when to stop, seeing the whole patient, not just the fact that they've had IBD for a long duration. So about their comorbidity, whether they're on anticoagulation or not, what kind of benefit risk harm versus benefit ratio we've got. And you really have to have those discussions with the patient to know when to stop. How do we do this? Because we've all been told different things and people get very hung up on the how do we do it? Do we use chromo in everybody? What do we do? If you really want to prevent colorectal cancer in an IBD surveillance service, these are the 4 take-home messages again and again and again. And that last one cannot be overemphasized. Concordance with surveillance recommendations. The biggest danger, and this is based on data, the Sesame cohort, which we can talk about, is that the biggest danger to patients developing cancer in an IBD cohort is the fact that they don't get their surveillance on time. They get overdue, they get forgotten in the sort of grim reality that we're in today. And that is the biggest danger more than anything else. These are the 4 most important interventions. But on top of that, it's really key to know when we say better disease control, the better your inflammation is controlled. That is one of the highest risk factors, far more so than the presence of dysplasia. If you've got poor control of inflammation, it is a really high risk factor for someone to develop cancer. And these are all the multivariable risk factors here, which you can see. Smoking, again, self-evident, but clearly a very, very powerful and consistent risk factor. Do ask your patients to stop smoking. And a timely colectomy. You cannot, in this era, once you've looked at used all your biologics, etc., I think we should by now be moving away from that patient who's struggling on and on and on and feeling absolutely exhausted and drained, and the clinician still thinking, well, let's throw something else in when it is time for that person to have a colectomy. This is the Sesame cohort just to illustrate the fact that a really big thing that's come out of these large, well-characterized cohorts is you don't get your surveillance on time, you're at risk of cancer. And so, what mechanisms can we actually have in practical terms to help us move forward? How are these guidelines going to support and underpin those? Well, there's a lot of telehealth health support now, phone letter reminders, people are getting texts about these things. People have got other things going on along with their IBT. They have associated mental health issues going on. We need to focus on those as well. Increase their clinical engagement with virtual clinics or whatever else. And IBD MDTs have a really key role to play in this. So that's the take-home message for a key message for this. Offer all the eligible IBD patients a colonoscopy 8 years after diagnosis or at the time of diagnosis if it's PSC, and within 6 months of their recommended surveillance. If it's getting more than 6 months, start kicking up a fuss, please, because those patients are going to have poor outcomes. They're really going to have poorer outcomes. So these are the key aspects that we've discussed, but it's not up to us as medics to say, this is what we're going to do and everything's going to be fine. This is the whole service approach. It comes down to our IBD nurses, our administrators, our coordinators, all the people involved in an IBD specialist service and the patients themselves so that we can take this forward. And among other things, and I'm grateful to James East for a lot of these slides because we share all our slides, and around the UK, you will find similar slides on these guidelines everywhere so that you're getting a consistent message. I've spoken about the 4 big things. Let's talk a little bit about chromocolonoscopy. I will talk a bit more about this tomorrow afternoon at the IBD session. But if you look at, should we be doing high definition chromocolonoscopy? We've published a separate network meta-analysis on this. And the answer is yes, we should. Is that what's going to make the most difference? No, it will make a difference, and it is better than all other modalities. So some of you may ask, hey, but hang on, what about the ASG and ESG saying you can use virtual chromocolonoscopy as well? Well, the simplest thing I would go back to is what I said earlier. The evidence is the same, and then you have to look at healthcare systems and what's going on there. You can use virtual as an almost equivalent, but if you're going by data, then high definition chromocolonoscopy certainly seems to have an edge. And this was again published as a network meta-analysis that we did. This was a really robust data analysis, so it would stand the test of whatever else we can throw at it. What about taking random biopsies? Well, not in everyone. And again, read the guidelines. What we've said is in the high risk groups, yes, you should, because we're not that great even with the best high definition chromo. But if it's not a high risk group, then you may not need to. And hopefully improve things for our pathology colleagues as well. So the take home message is, why do we offer colonoscopic surveillance? To prevent IBD-related colorectal cancer and detect cancer at a curable stage. There are some really practical things we can do as a whole service, and the technical aspects of colonoscopy is one aspect of those. So none of this is going to work if your patient doesn't attend. And that's not just a patient issue, it's a service issue. They have to be concordant with their surveillance. If there's again one take-home message, that's what we've got to take on. I'm going to move on now to the second guideline, and I hope you all find this also extremely helpful. This was led by Matt Rutter, and this is on the management of colorectal polyps in people with limited life expectancy, increasingly an issue that we all face in our clinics. So let me just start with a case very quickly. This is a 72-year-old man who was FIT positive on screening. He's a retired healthcare professional himself. He's in a nursing home. He's got significant issues with multimorbidity, early onset Parkinson's, Lewy body dementia, mobility, movement, position change, all really, really difficult. We already had a virtual video consultation. This is a true case from my practice. And then in the nursing home, discussed with the Parkinson's team as well about prognosis, etc. He was considered to have a very advanced stage of Parkinson's with significant frailty and debility. He still had capacity. And his wife was insistent that he wants to know, because he's had some weight loss, he's had some rectal bleeding. And we actually had a clinic discussion, discussed the risks, benefits, life expectancy, ability to take bowel prep, ability to move with a frame, lie down. And basically, and you'll see this in the guideline recommendation again, felt that perhaps a minimal prep CT is as far as we should go. And this is not really a suitable screening modality. So we really need to have clarity on what is benefit and what is risk. And this is what I'm going to talk about in the next few minutes. And you'll see this in the guideline recommendations as well. So what should we do? Withdraw from screening with the minimal prep CT. We did the CT that said thickening at the rectosigmoid. Maybe it's just fecal loading, or maybe it's something else. He had a flexi-sig, normal rectosigmoid, and no further interventions. So if you reflect on this, you got to balance the population perspective and service constraints at the same time without dismissing a person who may have a disability or who may have an illness where they may feel that they are not getting the same provision of care as somebody else. And it also depends on the severity of their comorbid health conditions. It's not just enough to have a condition. It's not just enough to say, oh, he's got liver disease or she's got heart disease and we can't do this. It's how severe is that? In today's day and age, the prognosis might still be excellent. So it is about drilling down into all of that. And then there are issues of capacity, consent, best interests, all the rest of it. And a basic problem we all face is that there are really poor scoring systems for multimorbidity. So in this guideline, it was not just a bunch of gastroenterologists sitting down. It was people representing all the relevant specialties, geriatricians, epidemiologists, all the relevant professions here. And most people find it helpful if the assessment, when you take them through the risk versus benefit, they often choose not to have further investigation because no one's actually sat down and told them that, you know what, this may not actually change how long you live or your quality of life. And sometimes we face very challenging situations. And so it's important we take an individualized approach. And hopefully what this guideline will do is give you a framework to do that. And it's also important to manage expectations. And you cannot exclude people simply, as I said, on the multimorbidity aspects. And there are ethical and legal considerations along with the resource and service constraints. So the score that we've used throughout is a well-validated, internationally recognized score, the Charlson Comorbidity Index, and it's the age-adjusted Charlson Comorbidity Index, which you'll see here. This is an abbreviated form. You get points for having certain multimorbidities, and you get points for the severity of illness, and that is how you'll see those tables presented. And hopefully in clinic, this is a very practical, useful way for these to be used. So I'm just going to dwell on this table just for a moment. So when you see a table like this, your eyes might glaze over and think, oh, what the hell does that mean? But if you look at the way the key to it at the bottom, you'll see this one summary table is based on a massive amount of work of Markov modeling that was done on every possible polyp scenario. The size of the polyp, the chance of it being malignant, all the data that went into that, the risk of a polypectomy from in a small polyp versus a big polyp. The key aspects to this is what is a really important feature is the patient on anticoagulation or not. That one single thing will often decide what kind of outcome that person has, including that if you stop that anticoagulation for a window period, the risk of a thromboembolic event. We've all had these patients every year. You'll find a trickle of them. If you don't keep track of them, you'll have those patients coming in with strokes because you stopped the Apixaban. You didn't actually discuss it properly. Patients had a stroke. They had a few little polyps that actually could have done with just staying there, wouldn't have affected their quality of life or their life expectancy. So the way these tables are presented is the red, amber, and green as to favors conservative management or favors intervention with polypectomy, and the amber being the equal or marginal case here. And you can see what, say, the row with a CCI of 4 would be in a 1 to 5 millimeter polyp. How many cancers would you get in the 7 years or so? These are all averaged out. So when you speak to the patient, you can say, look, in an average person of your age with your level of comorbidity, the number of cancers we'd find in 1,000 patients like you if we were doing the same thing would be 5 or 7 or whatever, so that they get an idea of what is that level of risk. Just as we do for when we're doing a colonoscopy and we go through the spiel, oh, 1 in 1,000 risk of perforation, blah, 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 this much risk of bleeding. It is important we give people some context to this. And that table is meant to be for shared decision making, not just a unilateral decision here. And so the summary of the recommendations, which you can see over here, and again, I won't read out this, but there's something that each level of our service can do from the time of somebody being referred in by the GP, somebody being actually vetted by the consultant, the coordinator who assesses that patient, and the person who's actually taking on the therapy. Each level can benefit quite a lot from being quite streamlined and seeing how it's going to help us with the benefit versus risk discussion with the patient. So if it's a simple diagnostic test, there's an algorithm there that you can see and you can decide whether you investigate or you don't investigate further, or if there's a non-invasive or less invasive modality that might reduce the risk and still give a reasonable level of benefit. If it's a therapeutic decision making, then you look at this differently. And many people might say, hey, look, those averages are all fine. My perforation rate isn't that. Surgical colleagues are well used to that. Yeah. The national audit says that, but my complication rate's always lower than that. That's okay if that's the case. Have the data to support it, and let's just discuss that with the patient so that we are really clear. In this day and age, it's very hard to hide behind that. Ombudsman reports, all these kind of things will dig up all your data. They'll dig up all national data. And the report the ombudsman will give you say, you were not realistic when you presented to this patient in clinic because your clinic letter says blah, 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 whereas actually your data doesn't seem to support that. So that's where these kind of tables will hopefully be really helpful in assessing an individual patient. I just want to dwell for the last 2 minutes on one thing, because I don't think we understand this concept of risk very well or life expectancy very well. So this is a game you can play if you feel like it. Go to the ONS website and just look up life expectancy calculator. Okay. So you just put an age there and the sex there, and the ONS will, it's a beautiful, very easy website. Say you've got a person of that age who's female and average life expectancy 86 years. Now, I'm sure I'm not alone in that a patient will interpret this as saying, are you saying I've only got 4 more years to live? And then you meet that person at a bus stop 5 years later and say, you gave me just 4 years to live, and look, I'm here at 5 years. That's not how we understand life expectancy. It's really key we understand this properly. It just means that there's a quarter of people who will live beyond that. And there's actually even a small chance you'll get a card from the king when you get to 100, but that chance is pretty small. So when we explain this to a patient, we have to be honest and we have to be realistic to say, look, these are averages. This means that this proportion of people in your condition with your comorbidity will actually live this long. I can't guarantee it. We can't promise you that, but that's how it is. And it's really key we understand what that risk means. So it's while there's uncertainty about the risk of polypectomy, these are what we know, and this is in the guidelines, this is from the guidelines. And the consequences of complications, it's important we go through those, but again, in an objective manner. So if you say to someone, I don't think he's fit for a haircut, that's okay. It's a summary statement, but it might be easier if you could support it with some scoring system that might tell you if haircuts come below or above that threshold. And then it might be reasonable to back it up if that situation arises. And the practicalities of decision making and patient communication. Again, we've got some great point statements and expert opinion statements, which you can read over there and the guidelines. And these discussions need to be held in a calm environment. This is not the discussion you have in the room, consent room, just before endoscopy. Please don't do that. I'm proud of the fact that in our unit for years, what we've done is got these patients in a calm environment, had that discussion way before we decide they're for therapy or not. And we sit down and actually say to them, you don't have to make a decision right now. Go home, have a think, have a chat with your family, ring up next week if you want, just let us know. And that actually, from a medical legal perspective, an ethical perspective, and a moral perspective, is the way to go. A calm environment, give people the information, allow them to have a shared decision making in their own what they want to do and how they see things. Not everyone will see it the same way. And I'll stop there. Thank you.
Thank you, Sanal. I think we might have time for one question if anyone's got anything burning. If not, I suggest we move on to the practical demo straight away, if that's all right. Thank you very much. That was brilliant.